Now I have the pleasure to move to next speaker, Professor Feras Badr, my dear friend, Professor Feras. He is a clinical professor of medicine, Cleveland Clinic, Lerner College of Medicine of Case Western Reserve University. He is Vice Chairman, Department of Cardiovascular Medicine. He's the Director, Section of Heart Failure and Transplant, Heart Vascular Institute, Cleveland Clinic, Abu Dhabi. And he's the Chairman of Heart Failure Working Group of Emirates Cardiac Society. Professor Feras.
Thank you very much, dear Professor Magdi, for the kind invitation. I also extend my thanks to Professor Khalid Shukri and congratulate him on the presidency of the Egyptian Society of Cardiology. It's a pleasure to be with you all today on this Saturday night. And it's especially a pleasure to be joined by colleagues from all over the Arab world, extending from UAE all the way to Tunisia. And it's definitely a pleasure to be joined by Professor Severovich from the European Heart Failure Association. So we've heard two elegant presentations already from Professor Leila and Professor Magdi on the diagnosis of heart failure, as well as the management of chronic heart failure with reduced ejection fraction. The next presentation is going to be mostly discussing acute decompensated heart failure. So as you can see, we're kind of moving in this in a chronological manner. And the goal from my presentation is to just highlight important aspects in relation to acute decompensated heart failure. I am not going to discuss every single medical approach to acute decompensated heart failure, but I'm going to highlight important concepts in the pathophysiology, specifically focus on the dialogue between the heart and the kidneys, and then reflect on the management and stress why decongestion is very important in the management of these patients, and then share with you some of the experience we've had in the management of acute decompensated heart failure from the Cleveland Clinic in Abu Dhabi. So this is what we call the three-phase terrain of lifetime readmission risk after acute heart failure hospitalization. Initially, when people are diagnosed, as you can see to the left side of the screen, there's a transitional phase where patients are still adjusting to their medications and self-care behaviors, and the risk of readmission is still high within that phase. Once evidence-based therapies are started in the management of heart failure patients, they go into a plateau phase where the risk is less than when they were first diagnosed. And then, of course, as the disease progresses, the risk of readmission for heart failure increases again. And that's when we start thinking about either palliative therapy or advanced therapies because of the progression of the disease. When we talk about pathophysiology, we have to remember that the same pathophysiology that Professor Magdi just presented a little while ago in the chronic state is similarly just enhanced in the acute state. So you do have an insult that kind of leads to some hemodynamic imbalance. The hemodynamic imbalance leads to neurohormonal activation, and that leads us through a cycle of hemodynamic compromise and more neurohormonal activation, leading to more and more symptoms, as well as direct cardiac damage over time. So naturally, with this kind of pathophysiology reactivating every now and then, every admission is associated with automatic worse prognosis in heart failure patients. We can't talk about acute decompensated heart failure without talking about this dialogue between the heart and the kidney. This is a must every time you manage a patient with acute decompensated heart failure. There's so much overlap in mechanistic pathways between the heart and the kidneys, be it the neurohormonal activation or the hemodynamics, to where there is no patient with acute decompensated heart failure without some level of renal derangement, whether we see it by the traditional renal assessment or we don't. This could be just the neurohormonal activation mechanisms, but it could also be the hemodynamic mechanisms in the form of the decreased cardiac output, and more importantly, as I will show you, the increased congestion in heart failure patients acutely decompensating. As a matter of fact, the so-called cardiorenal syndrome, which has 5 types, dedicated a specific type to worsening renal function in the setting of cardiogenic shock or acute decompensated heart failure, and that's type 1 cardiorenal syndrome. Now, people looked into why the kidneys deteriorate in the setting of acute decompensated heart failure and try to kind of dissect it to understand mechanistically how it happens. Initially we all thought it's probably because of the decreased cardiac index, but much of the recently developed literature actually highlighted that cardiac index is not the primary mechanism of why the kidneys deteriorate in acute decompensated heart failure. This is an elegant study that showed that for different ranges of cardiac index, as you can see, from less than 1.8 to normal cardiac index, if you look at different renal parameters, eGFR, BUN to creatinine ratio, or creatinine, there doesn't seem to be significant difference in the ranges of cardiac index between these different stages of renal disease. So people started thinking more along the lines of the congestion, the venous congestion. And this is a study that elegantly looked at the venous flow patterns inside the kidneys, ranging from a normal flow pattern of the venous wave, which is a continuous pattern, to a biphasic, to a monophasic, which is the worst type of the venous flow. And interestingly, when they compared that with invasive hemodynamics, it seemed that as you move from a benign venous waveform to a malignant venous waveform within the kidney, this correlated very, very well with filling pressures in the form of pulmonary capillary wedge pressure, right atrial pressure. Interestingly, cardiac index did not seem to be much different between the different venous waveforms. So once again, highlighting that it's the venous pressures, congestion, and that degree of that congestion that correlate very well with outcomes. And when we look into cumulative event-free probability and then correlate that with these types of venous waveforms, it is obvious that the most ominous types of venous waveforms, the monophasic types, are associated with the worst prognosis. Now, congestion is important. Congestion is associated with poor prognosis. Congestion is associated with poor outcomes. And it starts with just leaving the hospital. This is from the Everest study, and it looks at the 30-day outcomes according to the congestion status and the diuretic dose. So if you look to the left, it's the congested patients. If you look to the right, it's the non-congested patients, and the two colors just differentiate the dose of the diuretic. So the high dose of diuretic, patients who require higher doses of diuretic, unfortunately do worse than patients who do not require higher doses of diuretics. But if you compare the congested to the non-congested, it's clearly the case that congested patients end up doing worse than non-congested patients. Moving on to the clinical status, just looking at things like the jugular venous pressure or having an S3, clearly when patients were discharged according to the presence or absence of these signs of congestion, like the JVP or S3, people who had these clinical signs of congestion did worse than people who did not have it. As we talk about management of acute decompensated heart failure, and I take this from a nice consensus paper that was published in JACC in 2019, we have to understand what we call trajectories in the management of acute decompensated heart failure. Where in red here, it is the decompensation phase. In green, it is the initiation and uptitration of guideline-directed medical therapy. And in blue, it is the discharge coordination and then optimization of clinical care later on. Every time we have a patient with acute decompensated heart failure, we have to know which stage this patient is in now when it comes to this trajectory check. Because as it's a continuum, and as we manage somebody with decompensation, we have to be thinking about this decongestion, but then we also have to be thinking about the discharge coordination and then the initiation of medical therapy that will improve their overall outcomes later on. And we've already heard this in the previous two presentations as far as the diagnosis of heart failure and also the initiation of medical therapy, even as early as starting them during hospitalization, as Professor Magdi mentioned earlier. This is very important because if you don't manage acute decompensated heart failure with full awareness of their clinical status, many of them might leave the hospital in a decompensated state still. This is from the ADHERE registry, which is a huge registry from the United States. And it showed that about 16% of acute decompensated heart failure patients actually left the hospital with the same or more weight than the weight that they came into the hospital with. I mean, we know that patients don't eat better at the hospital. So this just indicates that their fluid status was not better when they left the hospital compared to when they came in. And we really have to be conscious of this as we manage these patients. Underlying etiologies have to be addressed. Just, declaring that this is acute decompensated heart failure without knowing the mechanism or the trigger for the decompensation is not enough. So it could be an arrhythmia, it could be an ischemic event, it could be pulmonary embolism, it could be an overload state like anemia or thyroid disease or pregnancy. But most importantly, it's dietary and medication non-adherence. And what that means is the value of education is incredibly high in patients who come in with acute decompensated heart failure. And very frequently, people come back to the hospital with acute decompensated heart failure because nobody ever educated them on the value of diet and medication compliance. So daily, patients have to be weighed at the hospital. Fluid intake in and out has to be strictly recorded. Vital signs, chemistries have to be checked because we're going to be managing these patients with intravenous diuretics most of the time. But it's very, very important to kind of have a continuum of how patients came in and how they're doing during the hospitalizations and how they are leaving it. Of course, assessing natriuretic peptides at the admission phase, but also pre-discharge is important, but it's not important to assess natriuretic peptides every day during the hospitalization because evidence shows that this is not helpful. And although we think this is common sense, it is actually not done most of the time. Not only do we need to assess patients from a congestion standpoint, but we also need to know if they're well perfusing or not. So this 2x2 breakdown of patients with acute decompensated heart failure tells us if they're congested or not congested, i.e. they're wet or dry, but it also tells us if they're warm or cold. Patients who are cold, meaning that they're showing signs of hypoperfusion, whether it's an altered mental status, significant hypotension, significant tachycardia, significant cold extremities with poor pulses, these patients might be in progressive cardiogenic shock, and managing them might require at least a temporary use of inotropes while kind of being very, very cautious with other medications that could potentially drop the cardiac output even more. The dose trial answered the question of whether or not we should use boluses or continuous infusion, whether we should use high or low dose strategy. As far as survival, and outcomes, there's no difference. But what we learned from the dose study is that if you use a higher dose, if it's boluses or continuous infusion, a higher dose will lead to faster relief of symptoms and without significant long-term harm on the kidneys especially, which means that being aggressive with diuresis early on is actually an encouraged thing because it will end up reducing heart failure admission duration. So this is where we're trying to move from congestion in the bottom to decongestion at the top. And this is how the patients look. No improvement in signs and symptoms, no decrease of nitric peptides, no decrease in weight. And then at the top, you have excellent improvement in signs and symptoms. You have no physical signs of congestion. And then, of course, you have significantly reduced nitric peptides before discharge, right before discharge. And there are certain complicating issues that could prevent the improvement from congestion to decongestion. Things like low cardiac output state, dominant right-sided failure, advanced renal disease, symptomatic hypotension, limitation of patient engagement in self-care. This is important because if you're trying to manage the patient by optimizing their volume status, by optimizing their diuretics, by optimizing the self-care behavior, but they're still eating salty food from outside or drinking a lot of fluids, then we didn't achieve anything. So engaging patients in self-care has to start on the first day they come into the hospital while we're introducing these therapies to decongest while we're introducing medications that improve their survival later on while we're kind of preparing them for discharge. Advanced renal disease, though, is a big, big factor in limiting the response of patients when they're admitted to the hospital. I want to reassure you that as you diurese patients appropriately for heart failure, the slight worsening that you can see in the kidney disease, as long as you're achieving successful diuresis, the slight worsening of renal disease is not ominous, okay? As a matter of fact, if you look at these curves carefully, to the left or to the right, you can see that outcomes in patients who have worsening kidney function with congestion in red are the worst, okay? But that's followed by not worsening of renal function and congestion in black. So patients who have no worsening of renal function and no congestion have the best prognosis, and followed to, by the, and this is followed by patients who have no worsening in renal function, but actually, so no worsening renal function, no congestion as the best, but then this is followed by worsening renal function with no congestion. A little bit of worsening of renal function is okay as long as you decongest patients appropriately in the setting of acute decompensated heart failure. It's better than leaving them congested, even if their kidney function remains the same. This is a very elegant analysis that looked at patients from the Feras heart failure trial, which used ultrafiltration versus standard therapy in acute decompensated heart failure. And this was just an analysis of patients who had the renal injury molecules measured. And I just wanted to highlight one specific thing from this analysis. If you look to the left at the randomization time, patients who had worsening or no worsening in the GFR, yes, no, for the decline in GFR, did not have a significant difference in the renal injury molecules. But then as we went to the randomization of ultrafiltration versus diuresis, and regardless of the strategy that was used, patients who had worsening in the renal function had increase in the renal injury molecules. But importantly, this was actually associated with more recovery. If you look at the renal recovery period, the patients who had evidence of injury ended up recovering their kidney function more. So what does that say? It says that if you really diurese patients or remove fluids effectively from them, the evidence of renal injury that you see early on is just temporary, and it will recover over time very nicely. This is better than people who do not develop this renal injury and remain congested. Always be conscious of other factors that could influence the interaction of the heart and the kidneys, using other medications that could harm the kidneys, using NSAIDs, chemotherapy, metformin, contrast material. These are things that we have to kind of be aware of when we're thinking about this interaction between the heart and the kidneys. So to kind of put it all together, consider higher doses of intravenous diuretics. It has to be significantly higher than their home dose of diuretics. Consider, and importantly, make sure they are continued on their guideline-directed medical therapy unless there is a hemodynamic compromise. So continue their ACEs or ARBs or RNA. Continue their beta blocker. They don't have to stop it unless they are in cardiogenic shock, okay? If they come in without being on these medications, you can start with the renin-angiotensin aldosterone system blockers earlier and then wait on the beta blockers until they're compensated. Initiation of beta blocker therapy at low dose is recommended before discharge from the hospital. Remember the DVT prophylaxis, and remember to check their ins and outs, their daily weights, and their kidney function with electrolytes every day. Don't make decisions just based on the change in kidney function. Put it all together, ins and outs, after the symptoms, weight, as well as kidney function. At the time of discharge, it's very, very important that we think of two important issues. Multidisciplinary heart failure involvement is very, very important. This is better to happen while the patient is still admitted, but if it doesn't, then coordinating this as an outpatient would be fantastic. And of course, every heart failure patient needs to be followed within 7 to 14 days after discharge, every single patient. This is just a glimpse at our Cleveland Clinic Abu Dhabi experience with heart failure, we kind of established something unique when it comes to heart failure management. Not only do we have a program that manages patients on the outpatient level, but we also have a dedicated heart failure service for these admissions to the hospital. So as you can see here, when patients come in with heart failure symptoms, depending on a specific algorithm, these patients could be admitted to the general cardiology service, to the heart failure service, or to hospital medicine service. And I'm not going to go through the specifics of this algorithm, but I just wanted to highlight that we actually have a separate service for heart failure admissions from the general cardiology. We kind of ran a retrospective analysis of patients who were admitted with heart failure before we established the separate heart failure service, and then after we established the heart failure service, to compare how patients did when they were admitted before the service was established to a general cardiology service, not an internal medicine service, and then after our service was established. This was looking at changes in renal function, differences in weight, need for ICU, need for inotropes, evidence-based discharge medications, length of stay, days of follow-up, 30-day readmission. We kind of looked at everything. And actually, we just submitted this manuscript for publication this week. So I'm sharing with you unpublished data, but this is just showing the baseline characteristics. And if you look at all of these baseline characteristics on the left, and you look at the first column here, this is before the heart failure service was built, and we looked at the last 90 admissions before we established the service. These, again, we're coming into a general cardiology service. And then after the heart failure service was built, and we looked at a similar number of admissions, we tried to kind of propensity match these two groups. And the P wave is not significant between these baseline characteristics. So we're admitting similar patients to the patients that were admitted before the service was built. But look at what happened as we incorporated a specific service for heart failure separate from cardiology service. Significant reduction in 30-day readmission, remarkable compared to before. Length of stay, significantly reduced. I can tell you, inotropic use was significantly less. ICU transfer was significantly less. Guideline-directed medical therapy, significantly more. And many other things that will hopefully come out in the manuscript that will be published at some point soon. So in summary, ladies and gentlemen, I wanted to emphasize a few points related to acute decompensated heart failure. Type 1 cardiorenal syndrome complicates the management of acute decompensated heart failure and carries a significant morbidity and mortality. Multiple neurohormonal and hemodynamic pathways contribute to its development and progression. Venous congestion, systemically and intrarenally, seems to be the major pathway in the pathophysiology of type 1 cardiorenal syndrome. And this is very important to keep in mind. The management of acute decompensated heart failure, when complicated by worsening renal function, requires multidisciplinary approach and careful assessment with close follow-up. The key approach is relieving congestion, sometimes even at the expense of mild renal dysfunction, and initiating therapies that are known to improve long-term outcomes. With that, I would like to thank you for your attention and thank the Egyptian Society of Cardiology for the invitation.
Thank you very much, Professor Feras, for this elegant presentation, as usual.
Thank you.
I can start my question.
Feras, thank you very much for an excellent talk. And my congratulations on your acute heart failure service. This is exactly what we are trying to spread all over the Europe with so-called quality of care centers in heart failure. That is just one proof that the medical approach should be everywhere similar, and we should use the experiences of each other. However, being in this field for a long time, I would like to use your presence to ask you about the entity of acute heart failure. So first of all, we know that we are very basically saying that we are very unsuccessful in finding the drugs which can be seen as a milestone in treatment of heart failure. Serelaxin failed. True HF with Urilatide failed. So we had both. We have a great hope on both of these drugs. So, but we were not able to prove that they are the efficacy in the long term and the improvement of the long-term outcomes. Therefore, that gives us the idea that we are not really hunting the real animal. So that gives us the idea that we may be dealing with a heterogeneous disease which needs to be treated as according to the etiology. So could you share some of the ideas we are trying to define, because Heart Failure Association was just about to form Acute World Congress, the World Congress on Acute Heart Failure, but due to everything what happened, we quit it. So I see that you have an excellent approach. You are using the most modern approaches, but do we know what we are dealing with?
You know, Professor Peter, thank you so much for your comments and your questions. And obviously, a lot has been done through the European Heart Failure Association to kind of dedicate more attention to the acute heart failure issue. But I think it starts with what Professor Leila talked about earlier in her first presentation. You know, we have to remember that when we talk about acute heart failure, it's not just heart failure with reduced ejection fraction that is coming to the hospital. It's a mixed population of heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, both going into episodes of decompensation. And heart failure with preserved ejection fraction in particular is so heterogeneous to make acute heart failure also very heterogeneous. Every patient that comes to the hospital represents its own category. So I could be on this, and having this acute heart failure service actually taught us a lot, because I would be rounding on a regular service on 10 patients. You know, some of them are the classic heart failure with reduced EF that came in because of their background of ischemic cardiomyopathy. You know, you diurese them, you know, but they came in having retained, I don't know, 10, 20 kilos sometimes of fluids before they decompensated. And then you go to the next room and it's a heart failure with preserved ejection fraction who you diurese 1 to 2 liters and the kidney function starts worsening, because they didn't really come in with significant volume overload. They came in with pulmonary edema in the setting of uncontrolled blood pressure. Another person came in with a pulmonary edema because they went into fast atrial fibrillation, and the fast atrial fibrillation.
So you basically agree that these are different subtypes?
Very different subtypes. And I think what needs to happen is that as we approach acute heart failure, we have to make it more of a continuum to the diverse approach to chronic heart failure, in the sense that we have to classify it. So it's not just acute heart failure in general. I think it should be acute heart failure in the setting of heart failure with reduced ejection fraction, acute heart failure in the setting with heart failure with preserved ejection fraction, acute heart failure in the setting of acute coronary syndrome, acute heart failure in the setting of arrhythmia. Perhaps if we divide them into categories like this, and divides, you know, and kind of end up with several, you know, different approaches, we could achieve more success. But just to have one recipe for all acute heart failure is very, very difficult and results in mixed result, you know, findings.
Absolutely, I would agree with you. Thank you very much. Thank you very much.
Feras, I just have one question for us. The value of treatment of those patients guided by BNB. So patients with acute decompensated heart failure should be treated guided by PNB, or conventional treatment guided by clinical evaluation only?
Yeah, I think at the time of admission, checking natriuretic peptides is helpful if you have a baseline from before, because you can then make sure that this is actual decompensation episode. And then checking BNP pre-discharge is helpful, because again, if you think that the patient clinically improved in a symptom standpoint, physical examination standpoint, weight reduction, significant negative balance, you know, compared to when they came in, then having this pre-discharge BNP will help you when next time the patient comes in with worsening symptoms, to know if this is another episode of decompensation or not. What people need to avoid is the serial measurements of BNP from day to day during the decompensation, because this has not really established itself in the management of acute decompensation.
Great, great. Any other questions? Okay. Thank you very much, Feras, for the excellent presentation.